any further delay, I will hand over to Sarah. As I said, she is the director of the Institute of Aging at the University of Oxford. And thank you again for joining us this morning, Sarah. Her talk will be on healthy life expectancy. What does the data say? And we all know, we heard this week that we have reached 8 billion. That's a data figure. So over to you, Sarah.
Richard, thank you very much. Thank you for inviting me, and I've got terrible feedback coming through. Oh no, it stopped. That's okay. Thank you very much for inviting me, and it's been an amazing week with all sorts of talks, and Richard asked if I would look at what the data said, and obviously I run a population aging institute, and so data and robust data is what underlies what we do. We use robust data evidence. Some of you may have heard my talk at UKRI, and what I did there was particularly look at how the data had changed after the pandemic. So I'm going to present some new data. I mean, it's not new, but it's new vis-a-vis that talk, which is where we thought we were before the pandemic. And then I'm going to show the slides actually that I've already showed on Tuesday for those of you who've already seen them, because I think that's some of the most robust data we have at the moment. And obviously between Tuesday and Friday, no new papers have come out or no new data. So for those of you who saw the slides at the end already, we're going to look at them in a slightly different way. So I want to put it in, sorry, my slides aren't now moving across. Yes. I want to put it in this perspective. This was the Healthy Aging Challenge. Many of you will remember when the world was a little different back in 2018. The UK Health Secretary announced that the then government, I don't know how many governments we've had since then, but the then government would aim to increase healthy life expectancy by at least 5 extra years by 2035 for England, and aim to reduce the gap in life expectancy between the richest and the poorest population groups. And I think this was a really important statement. They weren't saying we want to increase life expectancy, but we want to increase healthy life expectancy. And the way we want to do it is to reduce the gap between the richest and the poorest population groups in the UK. And I'm going to have this inequality theme there in the background. But I think the really interesting question for all of us is, even with advances in healthy life expectancy, will the pure increases in the number of older adults within our population actually increase morbidity within the population? And secondly, how has COVID altered that? Do we have any indication at the moment? And I'm going to take you through some of the concerns and look at what the data says. So I'm going to start with dementia. And I'm going to draw on 2 studies, both before the pandemic. One is the CFAS study out of Cambridge on the UK. And then I'm going to refer to the Health and Retirement Survey, which is a USA study. And those of you who remember when this was published, this came out in Nature in 2016. There was real hope that in actual fact, when we looked at age-specific incidence and prevalence of dementia in England in particular, we were seeing a decrease. So what the CFAS study has done and represented in this figure here, if you look at the turquoise blue line, which is CFAS 1, they estimated the number of incidents or the cases within the UK going forward based on 1991 figures. And they were then able to compare that with the purple line, which was about 20 years later, and actually showed from that that there was a fall in the actual cases vis-a-vis the projected cases. And in fact, the age-specific incidence and the age-specific prevalence of dementia within the UK was falling. And they came up with a variety of explanations for this. Maybe it was something to do with increased pharma, maybe just general increased health within the population. But also they questioned that old theory, which was around education. And this coincided with the publication in the same year of another study on dementia. This was in JAMA, the Journal of American Medical Association. where they looked at the prevalence of dementia in the United States between 2000 and 2012 and showed that the dementia prevalence by this particular study, the Health and Retirement Study on 21,000 UK adults over 65 or 65 and over, that it had declined significantly from 11.6% in 2000 to 8.8% in 2012. And their argument was that they could pick up the influence of 1 year's extra schooling with this particular cohort when they were younger. And it just so happened that this cohort had hit that time when the age of compulsory age of staying in school had shifted by 1 year. And they suggested that just this 1 extra years of education had this dramatic influence on the prevalence of dementia among the population in later life. And this draws on this cognitive reserve hypothesis, the idea that the clinical manifestation of dementia is delayed in people with higher education. And so I think putting those two studies together in terms of age-specific incidence and prevalence, that is actually very good news. But when we actually link it into this work, this was also published before the pandemic in 2017. And what this work does, it estimates the numbers of people with dementia by age and suggests that there will be a big increase in the numbers, even if incidence and prevalence continues to decline. And you can see that very clearly. This table compares between 2010 and 2040. And if we look at the sort of dark blue block in 2010, which is just before the 0.2 note, you will see that actually it is going to decline. So the incidence of dementia among people of that age and younger declines, but we still get a dramatic increase in the number of cases purely due to the increased number of older adults. And that's going to happen because life expectancy, we think, is going to continue to increase at the population level in the UK going forward. So even though the prevalence is decreasing, the data is telling us that there will be more cases.
Sarah, I'm really sorry, it's Richard here. We are not seeing your slides advance, so I'm really sorry for those who were online as well. It's an excellent talk. Now they're advancing. We are now on a slide that says ADL dependency at the top.
Yes, so the first time it took a long time to advance, and then it did. But you mean you haven't seen any of these slides?
No.
They did not.
Yeah, but now it's
now they are advancing.
Okay, but now I'm running it not as a PowerPoint, but as a sort of PDF. I have no idea why, as I say, you know, in fact, I was talking in China this morning at 6 a.m. on all this stuff, and it was working perfectly, but it was on Zoom. And I'm really sorry about this. As I said, there's some firewall, I think, with Oxford University. Teams simply doesn't work outside the university. So
This is now looking fine. Thank you.
Okay, so let's do this one. If I give it this way, does it work? It looks very sort of pathetic and amateurish, but
this is fine. This is looking good. Thank you very much.
So let me do it in this way. Okay, so if we then go on to look at ADL dependency, it's exactly the same kind of idea. That here, if you look at the red figures at the bottom, we can have a decrease in, for example, high dependency. So, you know, a 10% drop in the change in prevalence rate of the high dependence, but we will still have a dramatic increase in the numbers. And I think that's a very important statistic that we can actually, in terms of prevalence, we can really start to reduce that. But in actual fact, because we will still have so many more oldest old, we're going to have more morbidity within our population. And I just want to show you this slide, which I think is a very dramatic slide, which really shows this. This is shows ADL1. These are people unable to carry out one or more ADLs. And if you look, let's look at the slide on the right. We have men who are orange and women who are blue in a slight reversal of convention. And if we look at the prevalence rate, this particular study suggested that by 2025, the prevalence rate would be flattened or even actually falling a little. And yet in terms of cases, we would have an increase. So let's just move on to the next big question that we've been considering, which is obesity. I think it's very interesting that when the pandemic hit, we know that obesity was one of the risk factors. We've also known that it's been a risk factor for a variety of other chronic comorbidities. So, for example, higher BMI is associated with risk factors for vascular disease. We know that higher BMI is associated with an increased risk of diabetes, particularly as you can see at the very high levels of obesity. And we even have data which is suggesting that higher BMI is associated with reduced life expectancy. And I think the general picture has been that, in actual fact, obesity is a real risk factor, not only for individual diseases, but also for the sort of chronic comorbidities that combine to reduce healthy life expectancy. I then also want just to remind us of the inequality story, and this is a slide that I have used a lot. It comes out of the Foresight Review, which I chaired for the UK government in 2016, and it was based on ONS data, and I think it is such a striking slide. We know that there is huge inequality in life expectancy across our country, but this is looking at inequality not just on life expectancy, but also on healthy life expectancy. And so if you look at the sort of, I don't know, the sort of greeny blue long bars, that is life expectancy, and the olive bars are healthy life expectancy. And here we've mapped using ONS data between the most deprived areas of the UK, in fact, this is England, vis-a-vis the least deprived or the most affluent. And you can see very, very clearly that if you are a 65-year-old man living in the UK, then in fact, although you are very likely to make it to 80, all of your 70s are likely to be in ill health. Whereas if you are a 65-year-old man living in the top 3 most affluent areas or least deprived areas, you will probably live to your late 80s, and you probably won't go into ill health until you hit 80. So our 70s are completely dictated in terms of health by, if you like, our socioeconomic status, reflected here in areas of deprivation. And this is a very, very striking, I think, figure, which came out of Comrade, published in The Lancet again just before the pandemic in 2018. And it looks at crude incidence of heart failure and shows, if we look at the bottom, we have the least deprived, that's the pale blue, going up to the black, which are the most deprived, and tracking between 2002 and 2014, you can see consistently that those in the most deprived areas had significantly higher levels of heart failure. And they argue that we could actually reduce at the national level heart failure by 18% if we could bring the whole population down to the incidence of those living in the least deprived quintile. So we had a lot of evidence before the pandemic about the way that healthy life expectancy was panning out. There was a lot of, and there is a lot of very good data. So if we move on to say, what about the impact of COVID? A huge amount has been published. Some of it is a bit iffy. She says technically, I think most people, we edit a journal, and most people who edited journals at that time were inundated in 2020 and 2021 by very fast released papers on COVID. And some of them, I have to say, many of them actually were rejected, not just from our journal, but from many other journals. But we now, I think, are getting robust data on this question. So let's just look at a little bit of that. This is, I think, a very good study by Alberto that was published in the International Journal of Epidemiology this year. And what they did was they took basically a variety of European countries plus the United States, and they looked at life expectancy at birth and at age 60, and they compared how that had changed between 2015 and 2020. And let's just look at age 60. And what we need to look here is that women are red, men are blue, and you can see that 2015, that is the straight line, that's where we were. What happened to 2019, that's the plus, that's before the pandemic hit. And then what was the immediate hit of the pandemic? And if we just look at the top, we have, the longest lived population countries, which basically are Spain, France, Italy. Japan obviously isn't in there, Korea isn't in there because they're outside the region, but the countries we would expect are at the top. And let's just look at Spain, and the picture is very clear. that between 2015 and 2019, life expectancy at age 60 had increased as we expected, but it fell back quite dramatically in 2020. In fact, we had about 1.5 years loss in that one year, and the picture is replicated across those other countries. But what is really important to note that already, this is another paper published this year in Nature Human Behavior, and this is looking at the change in life expectancy between the 2019-2020 and the 2020-21 data. At the top, we have the United States and, in fact, many Eastern European countries where life expectancy continued to fall. But let's look further down where we have the grey arrows that are beginning to move backwards towards the right-hand side of the slide. And we start with England and Wales. And you can see that those bottom countries already within a year, life expectancy had turned back. And in fact, in terms of Sweden and Switzerland, and I think France, they were almost back to where one would have expected if the pandemic hadn't hit. So I think in terms of life expectancy, there are less concerns that life expectancy long term will actually have that much of an impact. But I want to look at this slide because I think this is a very important slide, and this looks at, again, this came out this year, also by Alberto, and this was published in the International Journal of Epidemiology. And what they're looking at here is life expectancy at birth, remembering, in fact, that a lot of the hit was in older ages, although there was some loss across the life course, and younger ages did contribute a bit to it, but the biggest hit was in the over 60s, obviously. And what they have done here, again, is men and women, but the dark blocks, that is losses in life expectancy or gains, but mainly losses due to COVID. And then the light lanes are other causes. And I think what's very interesting, let's just look at the United States for men. And what we have to remember is that although there was quite an impact from COVID, so we lost, the United States lost, say, over a year purely due to COVID, there also were other causes. And in the United States in particular, we know that life expectancy has been flattening and even declining. And, you know, we know Angus Deaton's work, which has looked particularly at the sort of midlife drop in life expectancy. And I think, therefore, we must remember that those kind of dynamics that were driving reduction in life expectancy still exist and are that underground sort of shadow, so that even when COVID retracts, those other factors are still there. Let's move on to this one, because obviously we're interested in healthy life expectancy. And I have to say really that there are some estimations, but there's very little robust data at the moment on the impact on healthy life expectancy. We have quite a lot of data coming out on individual diseases. I mean, and we know, for example, that respiratory disease, a disease around the cardiovascular system, there does seem to be, when we look at these individual diseases, that we are getting more young people who've had COVID getting morbidity in these particularly two areas than we would expect. And this isn't young, particularly men who've been hospitalized with COVID, they just have to have it. So even young men who had mild cases of COVID seem to be having an increase in some of these chronic comorbidities around the cardiovascular system and respiratory effects that we wouldn't expect. So we think there is evidence coming through there. But this is a really, really interesting study. And what they did here was that they looked at global health data. So it's across the globe. And they looked at 2020 into 2021. And they looked at years lost to COVID, which are the red. And then they looked at the years where we had an increase in disabled status, they believe, due to COVID. And you can see quite strikingly that, in fact, years lost to COVID went down, but years which contributed to ill health due to COVID have gone up. And I think the impact of long COVID on healthy life expectancy is something that we don't have strong evidence for, but I think it's something we have to keep an eye on. And I think there are two factors there. One, we have individual long COVID, but we also, of course, have the big impact on our healthcare systems. And without any doubt, we know in the UK, for example, that in terms of things like screening for cancer, we know that some of the interventions, again, around the cardiovascular system that we would have expected before the pandemic have been held up. And that's just because of the big hit that our healthcare systems have had. So I think we will see healthy life expectancy being affected. I think we will see robust data showing that. But at the moment, we don't have much data, but this is, I think, a very good study. And then to conclude, Richard asked me to talk a little bit about how this data contributed to policy recommendations. And I just want to take you back. And this is just 4 areas that I worked on, where my understanding of what was happening to life expectancy and healthy life expectancy contributed to government policy. I led the foresight review on the future of the aging population, and not only me, but obviously all sorts of other people. We had a lot of review documents and expert groups. It was a 2.5-year review. We had experts from different disciplines working, and it was a very, very robust data document. It's one of the last foresights that was done in this way. We had 24 review papers and, as I say, 2 years of workshops and visits. But I think it did begin to influence some of the thinking. Now, those of you who followed this know that David Cameron was a strong supporter of this review, and he personally decided that we should wait until the referendum was out of the way and launch the review in June 2016. And I'm sure all of you are aware of what happened in June 2016. And as a consequence, unfortunately, I think all the momentum that had been built up behind this report, which had very, very strong government support, obviously dissipated with Brexit. But behind the scenes, I have to say my colleagues in Whitehall have really tried to push into all the departments the importance of an ageing population. Part of that report influenced the work I did on the Prime Minister's Council, which down here we have the letter or the public that was written to, at that time, Theresa May, who'd taken over from David Cameron. It wasn't the only influence, but it was part of a group of influences that were really keen that we should get ageing into the industrial strategy. It became one of the grand challenges within the industrial strategy. And again, I think good progress was being made. And then we know there was another change of Prime Minister Boris Johnson came along. The levelling up agenda replaced to a certain extent the industrial strategy, although the grand challenges are still there. But again, very, very much data-based. And I've just highlighted another publication that Oxford worked on, where we talk about developing the Industrial Strategy Challenge Fund, healthy ageing, and trying, again, a very, very data-driven report. So I'm actually going to, I hope, stop sharing if I can work out how to do this. Okay.
Thank you very much, Sarah. You are still sharing.
I am still sharing. Do you remember last time we did this, I couldn't work out, stop sharing. I pressed that little thing. Wait a second. Oh dear. Have I stopped sharing yet?
So now we can see you, and I will also switch on the camera. So for those of you who are joining us on the internet, please do add your questions to the Q&A. At the top of the screen, you'll see a Q&A box. And while we're waiting for questions to come in, maybe I could start off by, again, thanking Sarah for joining us this morning. Sorry about the technical glitch. We are in the decade, the WHO designated decade of healthy aging. What do you think, Sarah, are the key challenges of this decade where we need to collect more robust data? What data is missing that would help us to better address a healthy aging decade?
I mean, I think the really important factor is that...
One moment, I will need to, put you back onto this screen so that we can hear you. Sarah, go ahead.
Can you hear me now?
Yes, we can.
I'm a bit echoey, sorry. I think the really important thing that has happened over the last decade is a real understanding of combining, if you like, social, behavioral and biological data. And I think this whole move around understanding cell to society. And can you hear me? Yes.
We can hear you. Please carry on.
Okay, and I think that the whole move around being able to combine biological data, social and behavioural data is really going to transform our understanding of ageing and of healthy ageing, and particularly our understanding of how social and behavioural actions across the life course at the cellular level can have an impact, and how actually our actions can be both positive and negative. So I would say that combination data is really, really important. We need a lot more public health data, but we also need those with the ability to be able to combine different types of data.
Great, thank you, Sarah. Are there any questions in the room? Reese, go ahead.
So regarding the lifespan variation,
I can't hear the question.
Don't worry, I will repeat it.
Okay.
Is there any contribution of different lifestyle factors that are driving this change in health span and lifespan? So lifestyle factors.
Yes. So I mean, I think we have a real understanding of that, and there is a huge amount of data out there about, you know, the sort of social behavioural aspects, and that is reflected at the national population level. And when I showed you those different, do you remember I showed you the life expectancy, and there were certain countries that are consistently ranked, and the evidence is quite robust that at the population level we know, you know, diet, reduction in alcohol, reduction in stress, being outside, having good social networks, etc. Over and over again, that is coming up, and it's coming up in case studies, and it's coming up in big data. So we do understand. The real problem I think we have is how to change people's behavior. And without any doubt, if you like, I think the pandemic was a wake-up call. And I talked a little bit about obesity and the impact of obesity in those people who were particularly affected by COVID. It wasn't only that. We know that older people, men, and certain ethnic minorities and those in poverty also seem to be affected. But things like obesity were obviously very important. But then we have a recession in this country, a cost of living crisis, etc., and all those public health initiatives, which I think the population had understood immediately after the pandemic, to a certain extent are now being dissipated. So I would say far more strong public health data helping us to understand how we can help populations change their behavior.
Thank you, Sarah. Any other questions? We have time for maybe one more question, or if anyone online would like to ask a question, please add it to the Q&A.
Public obviously.
So there's a question in the room about the public awareness that they can change their lifestyle, perhaps to reduce the risk of dementia. What work is being done to address that? So better consumer education, for example.
That is a really interesting. Now, this is not my area of expertise at all. I don't work on consumer education, but I did look at a study which was really fascinating. I think it's called Food Deserts. And what this study showed was that in certain, it was based in the UK, certain parts of the UK, we have a population, particularly of younger people, younger parents in particular, who are fully aware of the importance of nutrition and diet. But they live in areas where they simply can't purchase. It isn't even a cost thing. They just cannot get the kind of fresh fruit, vegetables, good quality food, because they don't have decent public transport, and all the shops around them supply basically, I think we conventionally call it junk food. And it's almost impossible for them to regularly access the kind of supermarkets that maybe our audience are used to, where you can buy high quality food. And I think looking at, if you like, the spatial environment and our communities, sort of community-based studies, understanding that people may have got the message, and as I say, I think COVID really helped with that, but simply live a life where, due to the structures of the community they live in, they are unable to satisfy what they know they should be doing?
Thank you, Sarah. I think that's a very relevant question as we progress through this morning, because technologies are available to better inform the consumer in the community. And we'll be hearing about some of these technologies in talks later on. So with that, I'd just like to thank again, Sarah. Thank you so much for joining us.